Yeah, gallstones. Good. Has anyone else got any others?
So people are saying cholecystitis,
Yeah.
hepatitis,
Yeah, good.
ectopic pregnancy.
Yeah, that's more right shoulder tip, but yeah. Okay, so like you said, gallstones, cholangitis, hepatitis, liver abscess, and then you also have to remember things in the thorax can sort of be referred to that area as well, such as cardiac causes and lung causes. So next, can anyone give me some for the epigastric region?
GORD, peptic ulcer disease, pancreatitis,
Yeah.
H. pylori, MI, gastritis.
Yeah, really good. So all the things you said. And then what about the left hypochondriac?
So gastric cancer, splenic rupture, splenic infarct, pyloric stenosis, hernias.
Okay, yeah, so you got the main ones here. They're mostly spleen stuff, and then also ulcers, like you said. So next, what about the right and left lumbar kind of linked together in this diagram? So the lumbar regions.
Renal colic, appendicitis, pyelonephritis, constipation, renal stones.
Yeah, really good. So the main ones for these areas are renal colic and pyelonephritis. Okay, and then how about the umbilical?
Pregnancy, AAA, appendicitis again, early appendicitis.
Yeah, really good.
Volvulus, small bowel obstruction, peritonitis.
Yeah, so the main ones are early appendicitis, mesenteric adenitis, Meckel's diverticulitis, but also some of the other ones you said as well. How about the right iliac?
Ectopic pregnancy, salpingitis, appendicitis again.
Yep, so appendicitis, Crohn's, ovarian cyst, ectopic pregnancy, hernias. And how about the hypogastric region?
Inguinal hernia, ovarian cancer, cystitis, UTIs, STIs.
Yeah, really good. So testicular torsion is an important one to remember. Urinary retention, cystitis, and then obviously only if they're pregnant, but placental abruption. And then finally, how about the left iliac?
Ulcerative colitis, AAA, diverticulitis.
Okay, yep. So here we've got diverticulitis, UC, constipation, ovarian cyst, and hernias. Okay, so that's just an overview of some of the conditions we might be covering today. I'm only going to go into detail of a few of the main ones, focusing on the ones that are common in exams and the ones that are particularly emergencies as well. Okay, so let's get started with a case. So the first case is a 49-year-old man who presents to ED complaining of severe mid-epigastric abdominal pain that radiates to the back. The pain improves when the patient leans forward or assumes the fetal position, and it's worse on deep inspiration and movement. He complains of nausea, vomiting, and anorexia, and gives a history of alcohol intake. He is tachycardic, tachypneic, and febrile with hypotension. He is slightly agitated and confused. So, does anyone have any ideas what this could be?
Pancreatitis.
Yeah, really good. Okay, so the first thing we're going to focus on is pancreatitis. So there's a mnemonic, which is I get smashed, which helps me remember the causes of pancreatitis. Does anyone know what any of these are?
So people are saying intoxication, iatrogenic, idiopathic, scorpion venom, gallstones, female, ethanol,
Okay.
triglycerides, trauma, ERCP, drugs. I get smashed.
Yeah. Yeah, so you've got a lot of the main ones there. So these are the causes. Gallstones are the most common cause and alcohol is the second most common. In case you wanted to know, the scorpion is only found in Trinidad and it's called Titis tritinalis. Okay, so then the presentation of pancreatitis. You get severe epigastric pain that goes through to the back and it's better on sitting forward. They get nausea and vomiting, they don't tend to want to eat, and there's signs of shock such as tachycardia and hypotension. You can also get pleural effusion. Most commonly this is on the left, and this is caused by the pancreas swelling beneath the diaphragm, and then this pushes up against the lungs and blocks the lymphatic drainage, and therefore the lymph collects in the lung. So that's something I didn't know personally. You can also get particular signs which are common in OSCEs and finals, which are called Cullen's and Gray Turner signs. So does anyone know what these signs are?
Bruising in the flank, bleeding, Cullen's is around the belly button.
Yep. Yep. So this is a picture of them. So on the left we have Cullen's. So that's bruising around the umbilicus, and then Gray Turner's is bruising around the flank. So these are caused by the autodigestion of vessels because pancreatic enzymes are released, and this leads to retroperitoneal hemorrhage, which then causes this bruising. Okay. So investigation for pancreatitis. You get raised amylase and lipase. Lipase is actually more sensitive and specific for pancreatitis, but amylase is often used more often in hospitals. And amylase has to be 3 times the upper limit of normal for it to be diagnostic of pancreatitis. You also get a raised white cell count, a raised CRP, raised glucose. You get a raised glucose because the cells in the pancreas produce insulin, and these are partly destroyed in pancreatitis, therefore less insulin is released. You also get low calcium, and you should do your clotting and LFTs because they can be deranged. For example, gallstones, if gallstones is the cause, you can get obstructive LFTs, and you might get DIC as well, so therefore clotting might be deranged. You can also do an ultrasound scan to look for the cause of gallstones, and a CT abdomen. A CT abdomen is good for showing the severity and complications of pancreatitis. Okay, so on admission, you should also do a Glasgow criteria score. The criteria can be remembered by spelling out the word pancreas. So you're looking at the oxygen, the age, the neutrophils, the calcium, the urea, the enzymes, albumin, and the glucose. Okay, and this is done to measure the severity of the pancreatitis. So if you're scoring 3 or more within 48 hours of onset of the symptoms, you should transfer your patient to ITU or HDU as they've got a very severe pancreatitis. Okay, next, the treatment of pancreatitis. So this is IV fluids, as they've often got signs of shock and hypotension. Oxygen if they've got low SATs. Analgesia, as they can be in a lot of pain. Nail by mouth, because you don't want to be stimulating the pancreas anymore. And the same reason for NG tube. A catheter to measure their fluid balance and urine output. And ERCP if they've got gallstones. So this picture on the right is just a picture of how an ERCP is carried out to remove gallstones. Okay. So next to our second case, a 42-year-old man presents with a week of intermittent upper abdominal pain. He describes the pain as dull, gnawing ache. The pain sometimes wakes him at night and is relieved by food and drinking milk. He has had a similar but milder episode 5 years ago, which was treated with omeprazole. The only abnormal finding on examination is mild epigastric tenderness on palpation of the abdomen. So, can anyone guess what this might be?
People are saying GORD, peptic ulcer, duodenal ulcer, gastric ulcer.
Yeah, really good. So this is meant to be peptic ulcers, in particular, this one, duodenal ulcer. So we're going to start with the causes of peptic ulcers. Can anyone take a guess from these pictures what the causes might be?
Helicobacter pylori.
Yep, really good.
Some medications like aspirin.
I think she said aspirin, some medications.
Oh, yeah.
People are also saying NSAIDs.
Yep, so aspirin is an NSAID. So yeah, NSAIDs cause it because they inhibit the COX enzyme, which means that there's decreased production of prostaglandin, and therefore decreased mucus, and therefore the lining of the stomach is less protected from the acid. As someone said, H. pylori can cause it. This is because it causes inflammation and therefore breakdown of the protective lining of the stomach. Along with the NSAIDs, SSRIs, steroids, and bisphosphonates can cause it as well. SES is meant to stand for Zollinger-Ellison syndrome, which is basically a gastronoma producing excess acid and therefore damage to the lining of the stomach. That final one in the bottom right is meant to be Crohn's disease because obviously you get ulcers and Crohn's disease as well. Okay, so the presentation of peptic ulcers: epigastric pain, nausea and vomiting, early satiety, and heartburn. I've also got a table here of the differences between gastric ulcers and duodenal ulcers. So duodenal ulcers are more common. They're relieved by eating, whereas gastric ulcers are worse on eating. You're more likely to get hematemesis in gastric ulcers because they're higher up in the GI tract, whereas duodenal ulcers you're more likely to get melena because they're lower. Gastric ulcers can be malignant, whereas duodenal ulcers don't tend to be, and you also get pain at night with duodenal ulcers. Okay, so the investigations of peptic ulcers: carbon urease breath test, serum antibodies, and stool antigen tests are all tests for H. pylori, as this is a cause of peptic ulcers, as I said. You can also do an OGD, but you only tend to do these if they've got red flags or symptoms despite treatment. And not everyone needs an OGD. Okay, you can also do an FBC to look for anemia in case there's bleeding from the ulcers. And you should biopsy gastric ulcers as well, because like I said previously, they can be malignant. Okay, and then I've also got the treatment here, so lifestyle. This is something you should definitely mention in OSCEs as well if they ask for the treatment. They would like to know about the lifestyle changes you can make. So smoking cessation, weight loss, and decreased alcohol are the main ones. If H. pylori is the cause of these peptic ulcers, you want to give them triple therapy, which is a PPI, such as lansoprazole or omeprazole, clarithromycin, and amoxicillin. You also want to review their medications because, as I said before, NSAIDs, SSRIs, steroids, and bisphosphonates can be a cause. You then give them a PPI for 4 to 8 weeks, and second line would be something like ranitidine. For gastric ulcers, you want to repeat the OGD because they may be malignant. Okay. Next. A 19-year-old man presents to ED with abdominal pain, anorexia, nausea, and a low-grade fever. Pain started in the mid-abdominal region 7 hours ago and is now in the right lower quadrant of the abdomen. The pain is steady and worse on coughing. Examination shows tenderness on palpation of McBurney's point, and he has a temperature of 38 degrees. So does anyone know what this could be?
People are saying acute appendicitis.
Yeah, so that's right. So appendicitis. So I've got some pictures here of some examination findings that you might find in appendicitis. Can anyone tell me what the top picture shows? Sorry, I mean the point that I've covered up. Does anyone know what this is called?
McBurney's point.
Yeah. So McBurney's point is 1/3 from the anterior superior iliac spine towards the umbilicus. So this is where the tip of the appendix is located in a normal appendix, and it's where it's most painful in appendicitis. Okay, so then can anyone tell me what the bottom left picture shows?
People are saying Rovsing's sign.
Yeah, really good. So Rovsing's sign is when you press on the right iliac fossa and it elicits pain in the, you press in the left iliac fossa and it elicits pain in the right iliac fossa. Okay, and then finally the bottom right picture.
Psoas's sign.
Yeah, so this is pain on hip extension. Okay. So it's normally in younger patients, but it can be in any age. The pain starts in the periumbilical area and moves to the right iliac fossa. It usually starts colicky, which means that it comes and goes like a squeezing motion, and it becomes constant, and it's worse on moving and coughing. So often these patients don't want to get up and walk around at all. They'll barely let you touch you because they're in so much pain. They don't eat, they've got nausea and vomiting, they've got a fever, tachycardia, and then the signs that I just mentioned before. And they also have guarding rigidity and rebound tenderness, which is signs of peritonism. Okay, so investigations. They've got a raised white cell count, raised CRP. You might want to do blood cultures because they could be septic. A group and save, as most of these patients will be going to theatre. An ultrasound scan, which will show you the dilated appendix. However, you can't always see the appendix on ultrasound scan depending on the position of the appendix. And then you may do a CT abdomen if the diagnosis is unclear. So the treatment. Appendicectomy is the main treatment. And then you also give IV fluids, you make them nil by mouth as they're going for surgery, and you give them analgesia as they can be in a lot of pain, and IV antibiotics. Okay, I'm going to stop here. Does anyone have any questions so far?
If people want to put things into the chat, I also wrote down a few that were asked before. So someone asked earlier, why does position help in pancreatitis?
Why does what, sir?
Why does position help in pancreatitis?
You mean why is it more painful in certain, why is it relieved?
I think so.
I don't know, that is something that I'd probably have to look up. I'm not sure. If you want to send me an email with any questions that I can't answer today, then I can look them up and get back to you on that. My email's on the first and last slide. Is there any other questions?
So someone's asking what IV fluids are used in pancreatitis. Would it be Ringer's or Hartmann's?
Do you know the answer?
Don't ask me.
Again, I'm not sure about that. I think Hartmann's, but yeah, I can't say for sure. I don't think they'd ask you a question like that in medical finals, that specific, but I'm not sure.
Someone said that Hartmann's is safe in pancreatitis, but I definitely always just go off your local guidelines because it will be in there.
Yeah, there'll be a protocol in most hospitals for things such as pancreatitis.
Someone said, why group and save? I think they mean group and save investigation in appendicitis. What is group and save?
Okay, so group and save is to find out a person's blood type, and obviously you want to do this if they're going for surgery, in case they need, like, in case they start bleeding and they need a transfusion. So yeah, it's to check the blood type.
And then someone's asked, could we repeat the presentation of a peptic ulcer and differentiation between a duodenal versus a peptic one?
Okay, so I can quickly go back. Oh, that's not okay. So presentation is here. So I'll just put that up for a minute. Was there anything specifically you wanted to go through with regards to that?
I think they said the differentiation between a duodenal versus a peptic, well, versus a gastric one, I'm guessing.
Okay, so the way you could tell the differences, as it says in that table, is that gastric ulcers are worse on eating, whereas duodenal ulcers are relieved by eating, and the pain tends to come a bit later, so like 4 hours after eating. You tend to get hematemesis, which is vomiting blood in gastric ulcers, whereas in duodenal ulcers you get melena, which is basically blood in your stool. It's a black tarry stool. Just because duodenal ulcers are further down the GI tract. Gastric ulcers can be malignant, whereas duodenals aren't malignant usually. And then also with duodenal ulcers, you get pain at night when they're lying down. So that's how you differentiate it in an exam question, would be those kind of symptoms. Okay, I hope that's okay.
Someone else has asked, is urine amylase or serum amylase more specific for pancreatitis?
Oh, okay. Wait, what?
Urine or serum amylase.
Okay, I've never really heard of urine amylase being done for pancreatitis, especially in hospitals. So they always just do a blood test and look for amylase on that.
So there are a few more. I don't know if you want to carry on or...
I'll carry on for now, just and then if there's any more questions, I can answer them at the end so that people can stay behind and I'll answer them then. So, okay, so we're up to case 4. So case 4 is a 61-year-old woman who presents to ED with a day history of progressive right upper quadrant pain, which is 8 out of 10. She says she's had a fever and has been unable to eat and drink due to her nausea. Her bowel movements are less frequent and have become loose. Her pain is not relieved by bowel movements and it's not related to food. On examination, she has a temperature of 39.4, a blood pressure of 97/58, a heart rate of 127, and a respiratory rate of 24, and her SATs are normal. She has jaundice in her eyes and right upper quadrant pain with no rebound, that's meant to say no rebound tenderness, and involuntary guarding on her right side. So does anyone have any ideas what this could be?
Cholecystitis, acute cholangitis.
Okay, so this is actually acute cholangitis. There's some lab results there as well, which I forgot to put up. So as you can see, her white cells are raised, her AST, ALT, ALP are all raised, as well as her bilirubin, but her amylase is normal. That's how you can tell that it's not pancreatitis. So yeah, this is acute cholangitis, and we'll go through why this is cholangitis rather than cholecystitis or biliary colic in a minute. So the presentation of cholangitis, there's something called Charcot's triad, which is a triad of jaundice, right upper quadrant pain, and fever. Okay, and then if you have hypotension and confusion along with this, it's called Raynaud's pentad. So this is something I used to get really confused with, the difference between cholecystitis, biliary colic, and cholangitis. But it's something that you will need to know for exams. So in biliary colic, it's intermittent pain, whereas in cholecystitis and cholangitis, it's a constant pain. In biliary colic, there's no fever, and the observations are all pretty normal, and there's also Murphy's negative. In cholecystitis and cholangitis, you'll both have raised white cells and CRP because it's an infective process. However, in cholangitis, they're usually a lot more ill. They can be septic and have septic shock, which is why their blood pressure and heart rate are more deranged. As well as that, their LFTs are usually deranged, especially if it's a stone causing it. So that would give you an obstructive pattern of bilirubin, ALP, and gamma GT being raised. Also, another thing to note is that you only get jaundice in ascending cholangitis. You don't get jaundice in the other two. Okay, so that table will be on there if you want to look back at the slides another time. So we'll move on for now. So the investigation for acute cholangitis, you have a raised white cell count, as I said before, a raised CRP, as it's an infectious process. LFTs are obstructive. You'll probably do blood cultures because they can be septic. You'll look at clotting because this can be deranged. Abdominal ultrasound scan will show dilated ducts, and if it's a stone that's causing the cholangitis, it will show the stones in the bile ducts as well. Okay, so the treatment is IV antibiotics and emergency ERCP. So this is an emergency because these patients are very ill. Okay. So our fifth case is a 70-year-old man who presents with acute onset colicky lower abdominal pain and distension. He's failing to pass flatus and feces for the last day. He reports a recent change in bowel habit with increased frequency of defecation, some weight loss, and some blood mixed in his stools. On examination, he is generally unwell, is pyrexial, and has a distended abdomen with tenderness in the right lower quadrant. He has an empty rectum on digital rectal examination. So does anyone have any ideas what this could be?
Acute diverticulitis.
Okay. Any others?
Lower GI bleed. Obstructed bowel. Ileus.
Yeah.
Perforation.
Okay. So this is meant to be a large bowel obstruction caused by a cancer. The reason that it's a cancer causing it is because he has some of the red flags of change in bowel habit, blood, weight loss. Okay, so we're going to go through bowel obstruction now. So there's 4 cardinal signs of bowel obstruction. Can anyone tell me what these are?
Distension, obstipation.
Any others?
Pain. Fecal vomiting, just vomiting.
Okay, so the 4 cardinal signs are abdominal pain, which is usually colicky. So again, that means it sort of comes and goes like a squeezing motion, and it's cramping. Vomiting, which, like someone said, can be feculent. Abdominal distension and absolute constipation. So absolute constipation means that they're not only not passing stools, but they're also not passing flatus as well. So then the other symptoms along with this, anorexia, tachycardia, tachypnea, absent or tinkling bowel sounds when you listen with your stethoscope, and peritonitis. Okay, so there's 2 main types of bowel obstruction, small versus large. So does anyone know the difference between small and large bowel obstruction?
Someone said the 369 rule.
Yeah, that's something we are going to come on to.
X-rays.
So in terms of the presentation, how might they be slightly different?
The localization of pain.
Yeah, really good.
I think someone said something about maybe an X-ray, the concertina effect is small bowel. Small bowel is more centrally. Someone said small bowel, nausea and vomiting comes on first, large bowel, constipation.
Yeah, that's really good. So here's a table comparing them. So in terms of the causes, small bowel obstruction is most commonly caused by hernias, adhesions and Crohn's, and large bowel is most commonly caused by tumours, diverticulitis, volvulus and feces. So the causes of small and large bowel obstruction were actually something that I was asked about in an OSCE, so this is something that you should know. And in the presentation, as someone said, there's earlier vomiting in small bowel obstruction, whereas it's usually a later presentation in large bowel obstruction. There's later constipation in small bowel obstruction, whereas it's earlier in large bowel obstruction. And this is obviously because the obstruction is higher up in small bowel, so it's going to come out the top end earlier in small bowel, whereas it's lower in large bowel. And then there's upper abdo pain in small bowel, and large bowel it's lower abdo pain. Okay, so X-rays. Can anyone tell me which one's the large bowel obstruction and which one's the small bowel obstruction?
Small is the left one, and people are saying the right is the large one.
Yeah, really good. Okay, so the way to tell the difference is that in small bowel, you see it in the center, it's more coil-like, and you have something called valvulae conniventes. So the valvular conniventes are these lines, and they go across the whole bowel, as shown in that with the arrow. Whereas in large bowel, it's more placed around the edge, and you have haustra, which is pointed here with the arrow, and haustra only go halfway across the bowel, so haustra halfway, that's how I remember it. Okay, and then the 3-6-9 rule. Does anyone know what this is referring to? I know someone mentioned it earlier.
Centimeters of dilation.
So does anyone know what 3 would be?
3 is the small intestine.
And then 6?
6, the large. And then someone said 9, the rectum.
Okay, so
9, the cecum, someone else said.
Yeah, so to tell if the bowel is dilated on an X-ray, a small bowel is should be less than 3 centimeters. The large bowel should be less than 6 centimeters, and the cecum should be less than 9 centimeters. So if they're above these measurements, it means that it's dilated, and that could possibly show obstruction. Okay, so some other investigations you might do as well are CT abdomen, erect chest X-ray. On erect chest X-ray, you'd be looking for air under the diaphragm, which is something called pneumoperitoneum, and that is looking for perforation. And then you'd also do your general bloods as well. Okay, so the treatment of bowel obstruction. If feces are the cause of obstruction, you'd obviously give them laxatives. You'd give them IV fluids and correct any electrolyte disturbances. And you'd do something called drip and suck with an NG tube. So the combination of IV fluids and NG tube is called drip and suck because the drip is the IV fluids and then the sucking is the NG tube. The reason you suck, you aspirate the stomach is because you're trying to decompress the bowel so that there's sort of less pressure on the bowel. You also give analgesia, you make them nil by mouth because obviously you don't want to be putting anything in there if it's obstructed. And you monitor the fluid balance by catheterizing them. Some of these may need surgery. It tends to be more large bowel obstruction that needs surgery rather than small bowel obstruction. So indications for surgery. A closed loop bowel obstruction or ischemia, these are both emergencies. Closed loop bowel is basically when 2 parts of the bowel are obstructed and therefore there's no outlet on the proximal or distal end. this means that there's progressive fluid accumulation within that section that's closed off. So it can therefore lead to perforation. Other indications for surgery are just general causes that need surgical correction, such as a tumour, and if they're failing to improve with conservative measures. Okay. So I'm just going to stop here. Is there any questions at this point?
Yeah, I have a question. Wouldn't laxative enemas increasing the pressure in the bowel not too much, so that we would have a risk of maybe perforation?
Someone said, could you clarify a closed loop bowel obstruction? What is a closed loop bowel obstruction?
Okay, yeah. So closed loop bowel is basically when there's two parts of the, rather than just one obstruction, there's two parts of the bowel obstructed, which means that this middle section, fluid just keeps accumulating because there's no proximal or distal outlet. So therefore, it's just going to keep getting bigger and bigger, because if there's only one obstruction, it can sort of come out the top or the bottom end, but if there's two obstructions, this middle section, the fluid has nowhere to go.
Okay. What analgesia is preferable for treating abdominal pain?
I think you just use the WHO ladder of analgesia. So you start with like eosinophil, paracetamol, NSAIDs, and then you go up to mild opiates, and then go up to stronger opiates such as morphine.
How do you identify ischemia without surgical exploration?
Okay, so I had this on the last slide. So the presentation of ischemia, the pain is worse on movement. There's focal tenderness and there's pyrexia.
Then someone's asked which antiemetics are appropriate in bowel obstruction.
Okay, I always get this mixed up. I'm pretty sure you can, okay, you probably need to double check this because I often get this mixed up. I'm pretty sure you can use ondansetron. God.
Someone's saying metoclopramide.
Is appropriate.
I think so.
Yeah.
Yeah.
There's one that I think it's, I have a feeling it's cyclazine that's inappropriate, but that's something that you'd have to double check, or you can drop me an email and I'll look it up.
I think I'm not sure if this was just a statement or a question, but aren't laxatives contraindicated in such a case? It may cause a perforation.
If you know that feces are the cause, then laxatives are okay. But obviously, if it's one of these other causes, you don't want to be giving them laxatives because that, yeah, it could cause a perforation.
I think that's it.
Okay, so we'll move on. So this slide, I've gone through the main ones I wanted to go through. This slide, I've just got a little summary of each condition. So I was just going to ask, let's start with testicular torsion. Does anyone know what the presentation of testicular torsion could be?
Acute onset twisting of the testes, unilateral scrotal pain, groin pain, absent reflex.
Okay, yeah, really good. And the reason I've got this in acute abdomen is because it's something that you need to think of in young males who have abdo pain, as testicular torsion can present as abdo pain, and it is an emergency. So does anyone know the main investigation for testicular torsion?
Ultrasound scan, surgical exploration.
Yeah. So ultrasound scan you can do, but you must not delay the surgical exploration. If you think that it's testicular torsion, then you should be going for the emergency exploration. And then finally, the treatment for testicular torsion.
Orchidoplexy, surgery,
Yeah.
untwist it.
Yeah, correct. So this is just a little summary of testicular torsion. You will be getting the slides after, so you can look back at this. Okay, and the reason we do bilateral orchidoplexy is because if you've had testicular torsion in one testes, it's quite likely that you might get it in the other testes. And this needs to be done within 6 hours to prevent necrosis. If there's necrosis, then they might have to have orchidectomy, which is basically removal of a testes, which we want to avoid. Okay, so next is ectopic pregnancy. Does anyone know how this might present?
Bleeding, PV bleeding,
Yeah.
abdominal pain,
Mm-hmm.
amenorrhea,
Yeah.
generalized abdo pain, mimicking appendicitis,
Yeah.
right iliac fossa pain or unilateral pain,
Yeah.
shoulder tip pain,
Really good.
hypotension.
Yeah, so I think you've got the main ones there. Does anyone know what investigations you'd do for ectopic pregnancy?
Transvaginal ultrasound scan,
Mm-hmm.
beta HCG, sorry.
Yeah.
Um,
Okay, and then what are the treatments for ectopic pregnancy?
methotrexate, salpingectomy.
Mm-hmm. Yeah, so you've got the main ones there. So just remember, any woman of reproductive age, you have to presume they're pregnant, and if they've got abdo pain, it could be ectopic pregnancy. Okay, so next is a ruptured abdominal aortic aneurysm. Can anyone tell me how this presents?
Ripping abdominal pain, acute onset, radiating to the back or flanks, hypertension, tearing pain between the shoulders, stomach pain, pulsatile mass, hypotension, collapse.
Yeah, so I think you've got the main ones there. How about the investigations?
CT, palpation, CT angiogram, ultrasound scan, surgery.
And finally, the treatment. I think someone's basically said it there, but
surgery.
Yeah, correct. Okay. Yeah. Okay. So if you already know that someone has a triple A, if you know that someone's already got a diagnosis of that and they present clinically, then you can just take them straight for emergency surgical repair, because you don't want to be waiting around for investigations if you know that's the cause. Okay, so finally, pyelonephritis. How does this present?
Flank pain, fever, venal angle tenderness, burning or micturition.
Yeah, okay, yeah, good. And then what investigations would you do?
An ultrasound scan, blood, MSU, midstream urine, urine culture, urine dip, electrolytes, unis, I'm guessing.
Okay. And then finally, what would the treatment be?
antibiotics,
Mhm.
IV antibiotics,
Mhm.
analgesia,
Yeah.
IV fluids.
Great. Okay. There we go. So yeah, the main thing to remember with this in terms of the presentation, it's a triad of unilateral loin pain, fevers and vomiting. And then also on top of that, you get the normal UTI symptoms of dysuria, urgency and hematuria. Okay, so that's just a summary there, and you can look back on the slides if you want to review that. So that's the end of our presentation. We have got a quiz on Kahoot next, but if there's any questions people would like to ask me now, fire away, or we can take questions afterwards as well.